Hello, everyone. This is Katrina. Again, I want to thank you all for taking the time out of your day to listen to my presentation / in-service about this project. I'm going to try my best to keep it succinct, but also comprehensive enough to where you guys feel comfortable enough getting the ball rolling. Please, please, please do not hesitate to contact me via text, phone call, or email. And then also, I'm going to provide you with some Google Hangout times and dates where we can get together if you feel like you have any additional questions that's beyond just the standard call, text, or email. All right, and so without wasting any time, I'll go ahead and share my screen and get started. Okay. All righty. Okay. And so, as many of you know, I'm pursuing my doctorate, and I've chosen to do a project on the management of depression in perinatal and postnatal patients in order to address an important need of our particular patient population. And so the purpose of this presentation is to share the data that I found, which is a culmination of literature reviews, chart audits, patient and team surveys, and patient tracers. And so I'm excited to announce that this project will be starting on Monday, April 15th. And I look forward to sharing this data with you all and orient you all to the initial plan of action. And so the aim of our project is to improve perinatal depression screening and patient-centered right care to 75% by 90 days. All right, and so let's briefly talk about why perinatal depression is a problem that needs to be addressed. And so 14 to 23% of all pregnant women will experience a depressive disorder. And so depression during pregnancy significantly increases the risk of preterm birth, low birth weight, intrauterine growth restriction to the same risk as a woman who smokes 10 or more cigarettes per day. And if that's not bad enough, untreated depression could also reduce breastfeeding rates, breastfeeding duration, and levels of immunoglobulin A. And in labor, it could also create a dysfunctional labor pattern and ineffective pain management. And not to mention, the annual cost of untreated depression in the United States is a whopping $5.7 billion. And that's when only taking into account the decrease in productivity and absences. And this number does not include the significant burden of disease. And so let's talk about why or how this all fits into our practice. And so all of the major obstetrical organizations such as ACNM, ACOG, USPSTF, Mental Health Association, and APA, so forth, recommend routine screening for depression perinatally. However, none of them provide recommendations for optimal timeframes. And so the Massachusetts Child Psychiatry Access Program, which for the sake of ease, we will refer to as MECPAP, created a toolkit for providers to use for the screening and managing of perinatal depression. And so on the left, you'll see that their recommendations for screening frequency. And so I did a chart audit a little bit ago of 20 patients, and it revealed that we screened 0% at their initial visit. We didn't screen those who were transferred into care. We didn't screen early in the third trimester. We weren't at that time screening patients at 2 weeks postpartum who were deemed at to have a higher risk for depression. And however, we did screen a whopping 100% of our 6-week postpartum patients that did come in for their appointment. Interesting enough, though, of the charts audited, 15% of our patients didn't show up for their 6-week follow-up appointment. And I looked out as far as 8 weeks. And so that is something to keep in mind. And then also, I did an anonymous survey of 10 patients postpartum, and I asked them if they would disclose to their midwife that they were depressed if she didn't ask. And the answers were scored from 1 to 5, with 5 being that they strongly agreed, and a score of 3.4 was obtained. And in addition to this, with another survey question, there was a moderate confidence level from patients on our ability to identify, manage, and provide resources for depression management, which surprised me a little bit. And so this demonstrates a significant opportunity for improvement. And I also do want to note that just because we do things a little bit differently, like we do a screening at 14 to 16 weeks, I wanted to see how many of those patients we were appropriately screening. And at that time, we were only screening 45% of those patients. All right. And so the objective of this project, in short, is to improve patient engagement in their own health, to improve our team engagement and quality improvement, to improve the administration of the right care or the proper management of depression, and to create a system that will work long after the implementation of this project. And most importantly, the objective is to improve the short-term and long-term well-being of both the mother and child. All right, so let's talk about how this project will flow. So the actual implementation of this project is 8 weeks long and is broken up into 4 PDSA cycles. In other words, a cycle is comprised of planning, doing, studying the results, and acting based on those results. And so after each short cycle, adjustments will be made and data will continue to be tracked with the intention of improving that process. And so let's talk about the description. Let's get into the meat of this project. And so starting with screening. Given the fact that we've implemented a new process for conducting the initial EPDS screening by jot forms, so the decision with myself and administration was to focus on solidifying and improving our current process for screenings. So let's briefly talk about what this should look like. So we want to continue screening between 14 to 16 weeks at their wellness planning visits for our patients that are transferred into care. At their initial OB visit, we'll go ahead and provide them the link for the jot forms like we are doing with our patients that are, who establish care with us like early in the pregnancy. And then we'll review the screening at before or prior to their second appointment. We are going to start screening all patients, which we've already started at 2 weeks postpartum, who have been identified as at risk. And we'll talk about what at risk should constitute, and then continue to screen our patients at 6 weeks postpartum. So what is the at-risk patient? Okay, someone who's had a traumatic birth. They have a history of depression. They're high anxiety. They have a newborn with complications. They've had an unplanned or unintended hospital delivery. They have poor resources, a teenager, women with significant breastfeeding issues, those who've had a depression screening of greater than 9 during their pregnancy. And of course, clinical judgment. Even if you can't put a finger on it, but you just have a hunch that this person should have follow-up, that person should come in for a 2-week postpartum appointment and be screened at that time. And so all patients with a screen of greater than 9 should be considered at risk for depression and be assisted with establishing a clear plan of care. And I'll come back to what this looks like specifically. And with any patient with a plan of care, is initially established, such as starting medications or recommending a counselor, we should rescreen in 4 weeks. We want to know, is our intervention helping, or is it they're not improving at all? And that way we can come up with an additional plan or refer to a psychiatrist as needed. All right, and so the EPDS form will be given to the patient via jot form like we've talked about. Our current process for scoring the depression screening for postpartum patients will remain unchanged at this time. And for the case management log, so I've created a personalized case management log specifically for depression. And so any patient with a depression score of greater than 9 will be added to this depression case management log. Anyone can do this. The task can be delegated to the clinic RN. It can be delegated to our MA, since she already currently uploads the depression screenings for our postpartum patients. And I've already discussed this with Nicole, and she's on board with this. And after the midwife sees the patient, she could tell the clinic RN or the MA what they've discussed and what the plan of care is, so that it can be reflected in the case management log. And I will show you what this looks like, and I will show you how to access this. And so the case management log will be on the company drive for everyone to have access to, RNs, MA, administration. Again, anyone can add the patient to the log, even if an EPDS has not been performed. So if you've communicated with the patient and determined that this patient is at risk, put it on the patient, add the patient to the depression case management log, put on the patient to-do list to perform a depression screening, and why. What was your judgment call for that? And then an appointment can be arranged based on that clinical judgment. And so for the brief intervention, so after the initial screening, all patients, regardless of their EPDS score, should be so at the wellness planning visit, basically, they should be educated on the importance of mental health in pregnancy. We want our patients to believe that we care about it and that we're capable of addressing it, and that we assess, we treat, and we refer as needed. And so a discussion about perinatal depression can also be added to our childbirth classes for additional educational opportunities. And this is something that we can discuss more or a little bit later as we move through the PDSA cycles. And so all patients with an EPDS score of greater than 9 would be offered to choose between receiving a patient engagement tool by Excel or as a physical copy. And so this patient engagement tool is something that I've personally created, and it is a daily mood and stress reduction tracker. This document will be saved also on our team's shared drive, so that all staff can easily share the document with the patient via maternity neighborhood messages, or print additional copies as needed. And again, I will show you what this form looks like. In addition to a brief intervention, our team engagement. So we currently have meetings every 2 weeks. And so I'm not trying to add additional meetings because I know that that can become cumbersome. So all I want to do is add this project or this discussion to the agenda, because I want to hear from you. I want to know what works. I want to know what doesn't work, and any ideas that you have, and just continue to modify this process. In addition to this, after each of these meetings, I'm going to send out a team attitudes and perception of process questionnaire. And that will also allow me to get feedback from people anonymously. And then for referral for treatment, patients who are not responding to medications, have an underlying bipolar disorder, who are suicidal, will be referred to or need to be referred to a psychiatrist. Okay, so I'm going to take a pause here and go ahead and show you guys what these documents look like and how to access it. So it's going to be under clinical ops. I happen to have mine shared on the on my desktop. And then you just scroll down to where it says depression management and click on that. And then so part of the reason what's been taking me, I was supposed to send this out to you guys yesterday. And part of the reason why I couldn't do that was I've been trying to delete this document that was added in error. So please, for now, ignore this case management log. Please only look at the daily mood and stress reduction tracker and the depression case management log. So I'll go ahead and start by opening up this depression daily mood and stress reduction tracker. Okay, so what I've done here is some patients are tech savvy and brilliant with it, and I want to find the easiest way for everybody for them to upload these documents. So I've put instructions as to how, for those who are tech savvy, or even if they're not tech savvy but want to try to do this, how they could take this Excel document and turn it into a shareable link. So what would happen is they would upload, once they followed these instructions, and they receive this through maternity neighborhood messages, the patient could then respond to the message with a link. When we click on the link, we could see in real time or live any updates that are made to this tracker. That way the patient never has to upload it again, and we could see it, and I can track it for tracking purposes and to see if it's being utilized, if it's making improvements in our patients, and be able to use this data. For patients who are not tech savvy and will struggle for the life of them to try to create this Google link, they have the option of just opening up this Google document. Every single day they could make adjustments to, here we go. Every single day they can they could add what their feelings are and what they're doing. And then they could just upload that document. That's a rolling document for me 2 to 3 times a week, which will end up being Monday, Wednesday, and Friday. Now, please tell them that I'm doing this for tracking purposes as a pilot thing, and that I want to see if it's helpful, if it's useful, and see if there's any correlation in this. Of course, nobody has to do this, but it would be really wonderful if they are able to upload it at these routine intervals for me to have access to. And the last option is going to be if patients hate using Excel, don't know what the heck is going on with it, I have paper copies that are already in the office that they can use, and they could just take a picture of it every, Monday, Wednesday, Friday, and upload it to Maternity Neighborhood for me to track. Okay, so what is this daily mood tracker that I'm talking about? So I've provided essentially 12 months of it, should this person love it and want to do it. They could put the month that they're currently in. So for us, it's April. They could track for 31 days in that month. If their sadness level is low, moderate, or high, each of those days, they could put in the hours of sleep that they're obtaining. They could put in what symptoms they're having. So are they having anxiety? Are they irritable? Are they suicidal? Any of those things. And then the stress reduction tracker, they could put what their current level of stress is. And then really cool, they could also put in their stress reduction technique. So this becomes a way of patients saying, oh, I didn't realize this is an opportunity for me to make, for example, I didn't know acupuncture therapy was helpful. I didn't know that omega-3 supplements are helpful. And they could put an X with each option that they've chosen to do, and and they could see if there's a correlation between the stress reduction what technique that they've chosen, and their stress level, and their sadness level, and their depression, mood symptoms, and their sleep. And it helps them stay engaged in their care. And it also helps me for tracking purposes to see if there's a correlation in things that are the most beneficial for a patient or not. And so as you could see, they have lots of months of this information, which I think is really, really cool. So I'm not going to belabor that. I'm going to go ahead and now just show you the depression case management log. So in the same folder, you can go ahead and open this, open in Excel. All right, so really cool. This, like I said, anybody can update this. So you would put in the patient name. And then if you hover over, in case you're ever confused and you don't feel like watching this lengthy video again, you can just see any particular instructions. So say this person's initial EPDS score was 14. A person whose EPDS score is between 13 and 15 is moderate risk. So you would put moderate. And what that helps is it gives us a quick snippet of who is at the highest risk, who is at the lowest risk. Say this person is suicidal. Suicidal is considered critical. So you put critical. And that just helps us pay attention to certain people, maybe a little bit more than others. And you could issue description is what's going on. This patient is suicidal. Their mother or father had just passed away. They were raped. Something that helps us basically put it into context, what is going on. And since this person is being on this case management log because their depression score is greater than 9, we know we need to do a 2-week postpartum visit and screen. So we would document what that was. They need to be seen at 6 weeks routinely. You document what that was. And then if we should be doing a follow-up screen after their initial EPDS. And so, or initially after starting some kind of management plan or medication. And so we would document what that EPDS score is. And again, I have instructions for what that looks like. So if we did a screen at 16 weeks, we would put, when it was 13, we'd put 13 at 16 weeks. If we did another screen again at 10 weeks postpartum, we would put 13 at 10 weeks postpartum, and so forth. And so the only other thing that I want on here that's important is, did you give the patient engagement tool out? Did we start medications? Yes, no, maybe it's not taken. Maybe the patient's choosing not to take it even though we've prescribed it. Or is it not applicable? Maybe the depression score was only 10 and the patient's going to try doing these changes such as exercise, and so medication was not relevant. So under that case, it's not applicable. And then, does the patient have a counselor? Yes, no, not applicable. Maybe you don't think it's necessary. Or is the patient have a counselor but choosing not to see the counselor? Okay. And then this part you don't have to answer. It's if the patient says to you, I hate this whole plan, I don't like it, or I love it. If you have any feedback, great, add it. That just helps me get an idea. What I've left in purple is things that I'm specifically going to be tracking. I'm going to be tracking how often the daily mood tracker is utilized. I'm going to track how often the stress reduction tool is utilized. Okay, and that is it on that. So I'm going to go ahead and exit this. Don't save. Great. All right, and let me go back to this presentation and just finish it up here. Okay. And so this is basically the paper form of the patient engagement tool. And I've already put that's where you could find it. And I've put the instructions there as well in case the patients want to do want to use the Excel document and say, okay, maybe I don't want to do the paper form. It's there as well. And I've provided 3 months worth of it. If the patient loves it and wants more of it, then they can, or maybe we'll run out of these documents and you guys want to know how to find it. Boom. You run out of copies. I've put copies in that folder that's called Depression Tracker. And then also, since we talked about MECPAP and their toolkits and how it's a wonderful resource for providers, this is a front and back toolkit that can be utilized. And basically, it has an algorithm for antidepressant treatment. And it also provides a management plan. So it says, for this depression screening, this is what you should recommend. For this depression score, this is what you should recommend. So I think it's really, really awesome. And it helps us kind of have a formalized way or a systematic approach to how we approach a certain score. And of course, clinical judgment should never be understated. All right. And so I just want to summarize everything really quickly, put it all in a quick snippet where we can refer back to. So team meetings, we're already hosting the bi-weekly team meetings. Nothing's going to change there. I'm just adding this to each team meeting, a discussion about it, a brief discussion. I'm going to send out a survey after these team meetings just to know, is it going well? Do you like it, hate it? Any recommendations that you have? The plan is to do this daily mood and stress reduction tracker, give it to all patients with a score greater than 9, or the patient that is considered at risk. Please, please, please discuss with the patient that we are piloting this new tool to help them become engaged in their well-being, and that we want to track to see if it's being utilized by our patients. Please ask that this document is uploaded every Monday, Wednesday, and Friday. And of course, once I see a patient in the case management log, I'm going to be reaching out to people, those patients, if they're not uploading it, and just say, hey, do you mind uploading this for me for tracking purposes, if you're okay with that, of course. We could also create a text expander, and I'll talk to Allison about that, if it makes it a little bit easier for a way to formalize how to send this message through Maternity Neighborhood to each patient. And please remember that the patient can choose between sending it as a Google link if they're tech savvy, they can upload the document, the Excel document, or they could simply just take a photo of their paper document, their paper form, and upload it at the intervals. And so this screening is going to be administered currently at the same plan that we've already been doing. So nothing's going to be changed about that. The only thing that I do think will be changed is that we do a follow-up screen after initiating an initial plan. All at-risk patients will be added to the case management log. So basically a patient with the EPDS greater than 9 by anyone, even if the EPDS was normal, but you talked to, or maybe they've never had a depression screening, but you've spoken to this patient and you believe something is up and this patient needs follow-up, please add them to the case management list. Please update the to-do list. And that way we are all keeping an eye on these patients. And of course, lastly, please check out that toolkit that I've put there. I think it's a really great resource and you guys might love it. And that's it, guys. I'd love to hear your thoughts. Please message, please call me or email me with any questions. If you'd prefer to review everything with me, please let me know if any of the Google Hangout times that I offer is of interest to you. Again, I sincerely thank you guys for taking the time out of your day to help us make a difference for our patients. And let me go ahead and stop sharing my screen. Thank you, thank you, thank you. I hope to hear from you guys soon. Let me know what you think.